Good evening, and welcome to our educational webinar on Lapiplasty 3D bunion correction. We appreciate you joining us. I'm Derek Pease, Digital Marketing Principal for Treese Medical Concepts. Treese Medical is the company who patented the Lapiplasty procedure and manufactures instrumentation and implants. Our goal here tonight is to provide you with quality information because we know that making a surgical decision is a decision that isn't taken lightly. We applaud you for empowering yourselves with information to make the best informed treatment decision you can. I will quickly get a couple of housekeeping items out of the way so we can get Dr. Ebonie Vincent of Orange County, California. First of all, you're all listening to the on mute, but you can ask questions throughout by clicking on the questions tab in your control, typing them in. We'll be answering questions sprinkled throughout the presentation and at its end. Email you an archived link of this presentation to refer back to within a few days. Well, lastly, I know you'll enjoy our surgeon speaker, Dr. Vincent. But if you are attending outside of the greater Orange County, California area, you can find locally trained doctors in your own area to consult with by visiting our patient website at alignmytoe.com. There's a prominent Find a Doctor button at the top of the homepage, searchable by zip code. With all that out of the way, I'll soon introduce tonight's surgeon speaker, Dr. Vincent. Dr. Vincent is a paid consultant of Treese Medical, and we appreciate her volunteering her time here tonight. Her experience is extensive, and her practice is a Lapiplasty Center of Excellence. Dr. Ebonie Vincent is a skilled foot and ankle surgeon with a distinguished background. She is trusted with people's feet worldwide. Her surgical prowess has been recognized internationally by the media, patients, and peers for her innovative surgical techniques and compassionate bedside manner. Known for her TLC TV series, You're Killing Me, she is in the world for helping in complicated foot and ankle conditions. We appreciate Dr. Vincent volunteering her time tonight. I will return to moderate a question and answer segment at the end. And with that, I now present to you Dr. Vincent. Dr. Vincent?
Hello, everyone. Thank you so much for joining. And I'm super excited to talk about Lapiplasty. It's been a life changer for a lot of my patients, so I can't wait to kind of dive deep and answer any of and all of your questions that you may have tonight. Just a quick background, the Lapiplasty has been FDA cleared since 2015. This is not an investigational device. It is a patented procedure. It has been manufactured by Treese Medical Concepts Incorporated, and it does require advanced training, and it's not offered by all surgeons. There are thousands of surgeons that are trained, and that there are lots of patients that have benefited by being treated by Lapiplasty. To find trained doctors that are trained in Lapiplasty, go to www.alignmytoe.com/doctor. The procedure is covered by most insurances, and Medicare cost and coverage do vary. So you do want to check with your provider about Lapiplasty 3D bunion correction. As with any medical treatment, individual results may vary. There are potential risks, and recovery takes time. Potential risks include, but are not limited to, infection, discomfort from the presence of the implant, loosening of the implant, and loss of correction with a non-union or a malunion. If either of these things occur, additional treatments may be needed. Additional information about risk is available at lapiplasty.com/patient risk information. Only a surgeon can tell you if the Lapiplasty procedure is right for you. The Lapiplasty 3D correction procedure is covered by one or more US patents. And for more information, just go to visit www.alignmytoe.com. All right, so let's get into it. So is bunion pain affecting your quality of life? If the answer is yes, then that's why you're here, and let's go over why the 3D bunion procedure is the right one for you. Usually you'll look down at your foot and you know that you have a bunion because you're noticing the bump. If you look at the picture versus a normal foot versus the bunion, usually people complain about the big bump on the side of their foot. Now, there are varying degrees of bunion deformities ranging from mild to severe. Mild being a little discomfort, all the way to severe, meaning that the toes start to cross over and you get a lot of irritation, especially with shoes and activity. Your entire body weight rests on your foot. And if you have a bunion deformity, it rests on your bunion. And so bunions do hurt very badly, and it does affect your lifestyle. Bunions can cause pain, swelling, they cause pressure and numbness because sometimes the nerves can get involved. And it gets worse as the bunion deformities get more deformed because you're not able to fit into shoes. It gets worse with standing or walking for long periods of time. So what are the causes of a bunion? A lot of people ask. There is a huge genetic predisposition for patients to have bunions. And it's not just a cosmetic problem, it is a biomechanic imbalance. And I try to drive this point home to my patients all the time. I like to do surgery on things that hurt, and bunions can hurt, and they are a biomechanical issue. It is made worse by constrained footwear and also the activities that a person does. Also, certain occupations can definitely aggravate the bunion, specifically people who have to wear certain types of shoes at their place of work, people who have to do certain activities, their bunions are made worse and can become more painful. High heels especially are problematic because you're putting all the pressure in the forefoot and it's crowding those toes in there, therefore making your bunion deformity even worse. Some of the frequently asked questions that I'm going to try to answer now is, am I a candidate to have your bunion treated? Juvenile bunions do occur, so I do require 12 years old or above to treat a bunion. I do get preoperative x-rays just to determine whether or not your growth plates are indeed closed or not. I like to do surgery with closed growth plates, but usually at age 12 or above, that is the case. As you age, the more comorbidities that you have. So for instance, if you are older, above 70 or so, you might have osteoporosis or osteopenia, which does we need to take into account for in the healing process when you are considering doing a foot surgery. Another question is there a bunion that's so severe that it can't be treated? My philosophy is if you can fix something biomechanically, I do believe that Lapiplasty can be of assistance. I have used Lapiplasty for bunions mostly, but I have used a Lapiplasty system for a first metatarsal phalangeal joint fusion, which is usually what is necessary if your bunions are so severe. And then I do see a lot of this going on too. What if I have had bunion surgery in the past? Believe it or not, I do see a lot of patients who have had a history of past bunion procedures, mostly a head procedure, and the bunion has reoccurred. I take those patients on a case-by-case basis based off of their weight-bearing x-rays to determine if the Lapiplasty is right for you. I have had a lot of success with bunion revisions with Lapiplasty. So bunions are a progressive disorder and they just won't go away on their own. A lot of times what happens is it starts very mild and the bunion gets worse. As the bunion gets worse, the toes start to cross over. People start to develop calluses underneath the bottoms of their feet, like little transfer lesions that make the ball of the foot hurt a lot more. You can get arthritis in the first metatarsal phalangeal joint, which can cause a lot of bone spurs. And then generally you'll have a lot of ball of the foot pain. And sometimes patients come in with very interesting contraptions for mostly the conservative options to fixing a bunion. The pain can be managed by certain devices that people use, but it will not correct for the problem in general. And we'll get into that, the reasons why later. But your pain can be managed in the early stages, but typically bunions worsen because they are a bony problem. So surgical correction is the only really definitive way to correct for a bunion deformity. So some of the conservative treatments, patients have toe spacers that they can put between their toes to kick the big toe joint back into a correct position. This helps inside of shoes and socks, and it helps while you wear it. But as soon as you take the toe spacer out, the bunion deformity goes right back to where it was. Some people use pads or splints inside of their shoes, and also inserts, all of which are great options to help relieve pain, and that's a conservative option as opposed to surgery. However, again, surgery is the most definitive options to correct for your bunions. So now we're going to get into the science of the bunions. Bunions are more than just a bump. Bumps are usually the first thing people notice, and that's the way that they are able to diagnose that they have a bunion. But the root cause of the bunion is actually more so in the midfoot. You have your first metatarsal bone that is off center and unstable from its neighboring bone called the cuneiform bone. And so it's a large misconception that the bunion is just an overgrowth of bone. It's literally the bone that's just not stable on its neighboring bone that's rotated in a bad position. So it's more of a complex deformity than people think. I want to kind of draw your attention to each of the three red arrows, if you will. The first red arrow is pointing to bones called the sesamoid bones. These are two bones that everybody has on the first metatarsal head, but because that bone is the metatarsal bone, which is the second arrow, is rotated, those sesamoid bones are out of position. So therefore, the third joint, or the third red arrow, is pointing to the unstable joint, which is the joint that is necessary to be fixed when correcting for a bunion and for the 3D bunion correcting procedure. So what do bunions look like on an x-ray? On the left hand, you can see a picture of a normal foot, and on the right, you can see a bunion. I'll draw your attention back to what we looked at on the animated picture, those two sesamoid bones on the left, they're facing downwards. You can see how they're in a good anatomical position on the normal foot, as opposed to the bunion where that whole metatarsal, his head is just rotated, and you can kind of see the sesamoid bones kind of waving at you. That's how you know that there's a bunion deformity, but you can see where the deformity lies is more so in the midfoot. And so, did you know that 87% of all bunions are misaligned in 3 dimensions, not 2? So let's get into that. So think of it kind of like the Leaning Tower of Pisa. It has an unstable foundation, so therefore the whole building leans to the side. If the foundation is unstable, the whole bone is unstable. So it also will cause the whole first metatarsal to be elevated. It will raise, and therefore it doesn't take part in the full weight-bearing surface. So what happens is a lot of times people come in and they know they have a bunion, but they're saying, oh, my bunion doesn't even hurt, but my second metatarsal hurts, or the ball of my foot hurts. And the reason for that is because you have the bunion, the rest of the toes are taking the brunt of the weight-bearing surface, and so they're getting the most of the pain. So you have to be cognizant of the biomechanics of your whole foot and how the bunion is affecting pretty much everything. So if you think about it like the axis on a car, the bone can rotate, causing abnormal wear and tear, and it throws the whole car out of alignment. Think of your foot as the car. Like if the car tires are rotated in any type of way, the whole car will kind of eventually be affected. So traditionally, people have done a 2-dimensional bunion surgery, which essentially entails cutting the head of the metatarsal bone and scooting the metatarsal head over and basically fusing it together with a couple screws. It's kind of a planned trauma like all surgeries, but this is actually misshaping your entire metatarsal bone. So if you kind of see this figure right here, you basically are just shaving the bone or trying to move the bone over, and it does not address the unstable joint. If you can see the space in between the first metatarsal and the second metatarsal, you see that you still have a really unstable construct or an unstable foundation. Similarly, if you just, cut the bone and move it over, it's the same unstable foundation. So you're only fixing the bunion in a two-dimensional way. This does look good. Sometimes people are like, it was great. My bone looks great. The bump is, technically gone. However, now the bone is crooked. Essentially, it's misshapen. The bone is not in the correct shape. And then you still have the unstable joint to contend with. So looks good on the outside, but not so much on the inside. And unfortunately, these 2D bunions do take, because 12 times the likelihood of reoccurrence with a 2D bunion procedure. If you don't address it in the 3D bunion way, 12 times as likely that you're going to get a reoccurring bunion. And 3 patients are actually pretty dissatisfied after a 2D bunion procedure. And then, like I said, you might be back seeking advice from a podiatrist, because up to 70% of patients who do the 2D bunion procedure experience reoccurrence over time. So let's talk about if the Lapiplasty 3D bunion correction is right for you. I love fixing bunions with Lapiplasty, especially if they're a first-time procedure person. Like I said, I do see a lot of patients that have had past bunions before, but it's always nice when you can get someone who's done it right the first time. So let's kind of get into the procedure of the Lapiplasty with the 3D bunion correction. Essentially, it's a really great system that's easily reproduced, and essentially the entire first metatarsal bone is rotated into a normal alignment. So if you can kind of see that the base of that first metatarsal bone is more so aligned with its midfoot bone, and then you can also see the spacing between the first and second metatarsals are way more narrow and not as wide as if you were to have that bunion procedure. And so we basically straighten out that metatarsal, and then the whole toe straightens out, and then there's no bump. It's really reliable with the plating system that the Lapiplasty uses. There's a dorsal plate that goes on the top of the bone, and then there's a medial plate that goes on the side of the bone, which is made from titanium. And it basically secures that unstable joint that was made stable. And because of this plating system, the recovery. So this is a before and after. This is the bunion on before the surgery, and this is a bunion after the Lapiplasty procedure. I'll again draw your attention to those sesamoid bones before and then after. You see the rotation of them, and then I'll draw your attention to the plating system. The top and the side plating systems firmly secure this joint, so that way there's a great chance of healing. Consequently, if we did a 2D bunion procedure, I kind of want you to take a look at that and see how the bone in the 2D procedure is misshapen. It's not correcting for the actual deformity of the base. So therefore, this person might have issues. This procedure on the left is called an MIS bunion. A lot of times people are concerned about scarring, and they seek out a minimally invasive surgery in order to fix things. I'm of the belief that if you want something done correctly, you have to do it where the foundation is. Unfortunately, the minimally invasive bunion surgery does not address the base of why you have the bunion. I personally do not do them. The MIS bunions, and I just feel as though it's a less stable construct. I have done traditional Lapidus bunionectomies in the past, and they're okay procedures. They attempt to address the base of the bone as well, but it doesn't fully rotate those sesamoid bones, and the plating construct is not as steady to a traditional Lapidus procedure where doctors can use anything from 4 screws, 3 screws, a plating system. It addresses the same joint, but it doesn't fully get that rotation, and it doesn't fully. And then if you see, a normal foot compared to the Lapiplasty, it looks the same. It looks like it's a pretty normal foot after having the Lapiplasty procedure. The metatarsal phalangeal joint, the first arrow, that big toe joint is still able to move freely, which is a lot of times what people are complaining about with the 2D bunion procedures. If you move the head of that first metatarsal, you might lose a lot of your range of motion in that big toe. So with the Lapiplasty procedure, by doing a fusion in the midfoot, you're freeing up the range of motion of that big toe joint. So a lot of people are very happy with the free range of motion of the MTP joint. And then you have what we set out to do in the first place, which is stabilize that tarsal metatarsal joint in the midfoot. Because it was unstable, now it's stable with the Lapiplasty. So with the Lapiplasty 3D bunion correction, you are fixing the root cause of your bunion deformity. You're performing it correctly the first time, and you are able to get back on your feet pretty quickly. I will go over kind of how I treat people in the post-operative course, so that way you can kind of get an idea of how things work. But before that, just so everyone knows, the Lapiplasty is tried and true and tested. There's over 15 published clinical articles with 97 and 99% success rate, phenomenal studies, and I've seen this reflected in my patient base for sure. So as with anything, like it's variable based off of the patient specifics with their health and their comorbidities, but the couple before and after surgeries and after the Lapiplasty surgery, you can see that the bump is gone, the foot is more stable, and if you were ever worried about scarring, usually the scars heal really great. I mean, you don't really even see this person's scar, but there is one on the dorsal side of the foot on the top, and then a little one like in the middle, so we can get the instrumentation in there. Same with this person, you're seeing before and after, before surgery, and then 12 weeks post-operatively. So like I said, the plating technology is really great in helping the recovery process be really, really good. So it is a patented titanium technology, and it's very low profile. I haven't had to remove many of these Lapiplasties at all. Patients generally don't ever feel the hardware, but you know, it's not like it can't happen, but it's very rare. So what can you expect? I usually perform the surgeries and then I see my patients within a week afterwards just to do a dressing change. It depends on the patient, but I am allowing my patients to walk 1 to 2 weeks after surgery. If my patients are younger, a little healthier, with no comorbidities whatsoever, I'm usually allowing them to walk in a cam boot a week after surgery. For other patients, I am waiting until I get post-operative x-rays, which is about 2 weeks after surgery. So no weight bearing for 2 weeks until I see x-rays, and then I'll allow the patients to walk in a boot. The boot would be your best friend for the next 4 to 6 weeks. That is the only thing that you're able to walk in. And I drive the patients home, the point that you cannot bear weight without the boot. It's very important that while this is still a much better recovery period, you can't take more liberties than your body is ready for, because your bone will not heal yet. In that 4 to 6 week period, it's still healing. So you have to wear the boot. This does prevent you from having to wear a hard cast and having to be cut out of the cast, but you have to be compliant with the boot. I'm usually transferring my patients out of the boot and into a supportive, comfortable shoe at about week 7 on average. Sometimes it's variable based off of the patient base. Sometimes it's week 6, sometimes week 8. But I always check with the x-rays to make sure I'm deciding with the patient when it's time to get back into shoes. And generally, that's when the patients can kind of take off with their recovery, gradually at first and then better and better. And at about 4 to 6 months, you can pretty much do everything that you were doing prior to having your. So day 1 through 5, like right after surgery, I am prescribing pain medications and anti-inflammatory medications because it is still foot surgery. It's not going to be painless, but it is far less, making sure my patients are comfortable and they're always wearing their boot and I like to be the first one to do their dressing change just to make sure that no infection is going to ensue. I always tell my patients to keep their dressings clean, dry, and intact, and I will see you to change the dressing. So no reason for you to go ahead and change the dressing. I will do it for you. All I ask is that patients do ice the behind their knee, elevate, and take a lot of rest. So the first post-op visit is when you get to see everything. It's a big reveal. Essentially, I'm just removing the dressings, making sure no infection is taking place, and we replace the dressings, but you'll see the fact that you are well on your way to healing without a bunion. You can expect there to be sutures in your skin, mild bruising or swelling. So, I mean, it's still, your body's going to be healing, but it is going to be hopefully an exciting experience to see that your bump is gone. At 2.5 weeks, 2.5 to 3 weeks, I am removing the sutures, and that's when patients start to feel their nerves kind of waking up. Tingling, burning, kind of sharp shooting pain. It shouldn't be too bad to the point where your people are taking medicine, but it is there. Your body's like still recovering, and the nerves generally are usually the last things to heal. I always drive home the point that as we continue to progress in healing, you can expect swelling. The foot is the furthest thing away from your heart, so you're going to have to elevate it to make sure we get all that swelling out. So rest, ice, and elevation is something that you're going to have to do throughout your recovery period. At 6 to 8 weeks, I am putting patients back into shoes. So that's exciting. It's an exciting day. I make sure I give my patients a required shoe list, because not all shoes are created equal. Can't have you go from a cam boot into just a regular kind of shoe that's not as supportive. So I do make my patients get something on my shoe list that I trust to kind of gradually build them back up into their activity. At about week 7 or 8, I'm having patients get back into their activities, really. If it's your right foot, patients generally ask like, okay, so when can I drive? I usually start them being able to drive at about week 6 and 7, because that way you can drive with your shoe on. Anytime before then, you are putting yourself at risk. I'm not sure how far you're driving, but any type of slamming on the brakes can be kind of risky. So you want to make sure that you do have that support for about, a month and a half. So that way people can drive you around. So that way you're not putting yourself at risk. At about week 12, I mean, that's pretty much when you're starting to get a lot more normal. You can increase your activity. You can get into most shoes that you want to. You're able to soak your foot, swim. But at this point in time, you can still expect to have some level of swelling, because your activity will be more. I tell my patients all the time, like, that the swelling can last pretty much up to 6 months, depending on your level of activity that you're trying to reach. Again, if your foot did have surgery on it, it's stable, it's great, it's still healing, but it will still swell based off of your activities. And 4 months post-op, we're pretty much done. Like we're pretty much dancing you out of the office. You can do all of your activities. You can be barefoot, and you can basically call as needed. And so it's actually a pretty swift recovery period comparatively, and I'm usually having a lot of success and happy patients. So just a few frequently asked questions. When can I expect to return to work? This question varies depending on the patient's occupation. For instance, if you have a sedentary job, you can go back pretty much at a week or 2. I'm asking people to go ahead and be sure to ice exactly like every day. Make sure that if you can elevate your foot at work, please do so. But yeah, you can go back to work as soon as possible, especially if you have a sedentary job. If you're a person who is on your feet all day, such as in the healthcare field, or if you're a construction worker or have to be in steel-toed boots of any kind, I'm usually requiring you take off that 6 weeks before you get back into shoes. And even then, we'll have to have a specific conversation about what your duties are, because sometimes people are able to do part-time, light duty with restrictions. I usually talk to every patient about what their restrictions are based off of their individual needs. When will I be able to drive if my right foot is treated? The swift answer is about 6 weeks after surgery. And that will largely depend on your x-rays and how you recover. Again, I try to tailor everybody's post-operative care specifically to them. And is it possible to have both feet treated at once? Anything's possible. I do not recommend that you do it. I have done it on occasion, and I always tell people, you know, you want to bring whoever's taking care of you into the office, because I need to talk to them more about how to take care of you, because inevitably what happens is you don't know how dependent you're going to be on your significant other or your loved ones. And halfway through the recovery period, most people start to feel guilty. And then most people try to do more than they should be doing. So I don't recommend it. I tell everybody that if you've never had foot surgery before, you definitely don't want to go in guns blazing with doing 2 feet at a time. 1 foot at a time is great. And then I have been in the practice of doing 1 foot and then 7 weeks later doing the other foot. So if you don't want a huge recovery time, you can do it back to back, and that has worked out very well for me in the past. All right, so it's great to know your options, and just so you know that Lapiplasty does kind of check off all the boxes of how to go about fixing your bunion deformity. It corrects all 3 bunion deformity dimensions. It realigns the entire metatarsal bone. It actually addresses the root cause of why you have the bunion. So all things counted, it's really a great procedure. But as a reminder, as with any medical treatment, individual results are going to vary, and there are potential risks with every surgery recovery, and recovery does take time. You know, like I said, the foot is the furthest thing away from your heart. It's the last to get the blood flow. It's the last to get the swelling away. So you are going to have to be patient with your foot. But I have had a lot of happy patients with undergoing the Lapiplasty procedure. So if any of the adverse reactions occur, like infection or discomfort from the implant, loosening of the implant, or a non-union or a malunion, of course, there's going to be other subsequent procedures. Those are all things you have to understand that can happen during surgery. So if you are looking for a Lapiplasty trained surgeon, again, go to alignmytoe.com/doctor, and you can find someone in your area who does the Lapiplasty. So right now, I'll be answering any questions that come about, and I will do my best to answer them.
Yeah. And we've had several questions come in this evening, so thank you for the great audience participation. We'll do our best to answer most, if not all, of the submitted questions now. If you haven't yet, as a reminder, you may ask a question by clicking on the Questions tab in your control bar and typing it into us. Before I turn your questions over to the doctor, I'll start by answering a quick question that has come in repetitively during the presentation. Is the Lapiplasty procedure covered by insurance and/or Medicare? The answer is yes. When the procedure is deemed medically necessary, insurance and Medicare typically cover the bunionectomy and joint fusion procedures that utilize the Lapiplasty system. If your doctor determines that Lapiplasty procedure is right for you, he or she can reach out to your insurer to determine your specific level of coverage. It's now to get into some other good specific questions. Doctor came in throughout the presentation. One of them is type of movement allowed while wearing the boot. Should I wiggle and bend my toes? You know, if so, how often and how much?
So I do allow patients to move their ankle. I know a lot of times patients after surgery, they're in their like splint afterwards, and then they're in the boot afterwards. I do allow patients to move their ankle because nothing was done to the ankle joint. I prefer patients to wait to move their toes and try and flex some range of motion until about 2 weeks after the surgery. But other than that, as long as we're not putting pressure on the midfoot area, then we're good.
Next one. Does stabilizing the joint prevent any movement in the foot?
No, so it's the midfoot that is supposed to be stable. Your forefoot is the one that's responsible for pushing off and walking. So you want to have more motion in the forefoot. Where we're fusing your bone in the midfoot, that's where you're already unstable, and that's why you have the bunion in the first place. So it actually benefits you from having a more stable midfoot.
Okay. Do you shave the bump in the Lapiplasty procedure?
It depends. I am sometimes shaving the bump afterwards based off of the severity of the bunion. A lot of times people who had bunions for a really long time have a lot of arthritis that build up. And even when you rotate the bone in a perfect position, that buildup of arthritic bone, it's still there. So yes, I am sometimes shaving off that arthritic portion, but after I rotate it, so it doesn't misshape the bone.
Okay, and this is another common one as well, and I know some joined late, but if I have arthritis, would that prohibit me from being a candidate for the Lapiplasty procedure?
It depends on the severity of the arthritis, but no, most of the time it doesn't. The arthritis in the midfoot is probably because it's been unstable for so long, and that's pretty much your diagnosis. I'm diagnosing people with osteoarthritis of the midfoot joint. If you're talking about your big toe, if your big toe has like rigidness or you can't move your big toe and that toe is arthritic, then we might have to talk about a different procedure.
What, if any, risk is there of recurrence for somebody who may be an extreme use candidate, like a soccer player or a frequent runner?
So I would just be careful in the postoperative course for hardcore athletes to not try and do too much too soon. But I don't think that the reoccurrence rate is any higher for those patients. I mean, we have
able to return to those activities such as soccer or running?
Absolutely. Yeah. I mean, I've had workout instructors, skiers, athletes, even soccer players that have returned to full activity with absolutely no issue.
Okay, great. This one is, will I be able to wear high heels again?
Yes, I get that question a lot.
Unpopular one.
It's a popular one. Yes, you will be able to get into high heels. Like I said, the reason why people ask that is because they're afraid of the lack of motion in their big toe. We are not touching that joint of the mid toe, so you should have range of motion in order to get back into high heel shoes.
Okay. Let's see. There's some really good ones just coming in here. So this is a very specific one. This is, I have a son with special needs who needs transferring.
I'm sorry, you kind of broke up there.
I'm sorry. I have a son with special needs who needs transferring in and out of a wheelchair. How soon would I be able to help him do that again?
To help him transfer out of the wheelchair?
Correct.
So if he's able to wait about 4 weeks at the very least, that would be helpful. You can help them their weight in and out of the chair at 4 weeks, but only within the boot. It depends on what your special needs are, that we can kind of get more specific as to what the need is, and I can better assess that question. But yeah, 4 weeks is probably the bare minimum where you can kind of try and help.
Okay. Another common one here is, if I have a hammer toe, can that be done at the same time with the Lapiplasty procedure?
Yes, I do a lot of Lapiplasty procedures with other adjunct procedures. When I am doing the other adjunct procedures like the hammer toes, it depends on the procedure and the severity, but it might increase the time in which you cannot bear weight. So all of the postoperative course of the Lapiplasty is saying like you can walk in 1 to 2 weeks. That might be extended if we do another procedure like a hammer toe.
Was somebody required to take a bone density test first before the procedure?
If you've been diagnosed with osteoporosis, yes. That kind of helps better estimate or have us guesstimate when your recovery will be finalized. With my patients with osteoporosis, I am being more cautious with them with their postoperative care because you're for hardware loosening and reoccurrence.
Okay, thank you, doctor. Is physical therapy part of the post-op procedure?
It depends. Some patients need physical therapy and some don't. I'm always giving my patients physical therapy if they request it and if I feel as though they could benefit from it, especially when patients need a little bit more range of motion and a little bit more trust to like push off their foot in a different way and make sure that that range of motion comes back adequately. So yes, physical therapy, I'm usually giving them physical therapy around week 6 when they get back into shoes.
Okay. And a couple of follow-up questions as well, just for some we had that join a little bit later, kind of surrounding how quickly I could walk and when to return to work. So somebody wants to know, I'm an ICU nurse manager. Can I return to work after 2 weeks if I'm wearing the boot?
You said an ICU nurse manager?
Correct. I want to know if after 2 weeks, if they're wearing the boot, if they could return to work.
I would say you have to check with your job about if you're able to wear a cam boot at work. I know for some hospitals they don't want anybody in paraphernalia or any type of boots. So I would say it's fine to walk in a boot. It depends. Like if you're on your feet all the time and you're running through the ICU, then I would say you probably want to just take off the full 4 weeks, at least. But if you're able to kind of mitigate how much you're walking and kind of sit down a little bit throughout the day, then yeah, by all means, if you're able to wear your cam boot, you can go back in 2 weeks.
Okay. Are crutches required after the surgery?
I'm giving all of my patients surgical crutches because I do surgery on a Friday and I don't see my patients until that following week on like Wednesday or Thursday, and I require them to bear no weight. I want nobody bearing weight until I see you and we can kind of debrief afterwards when you're fully awake and not on anesthesia. So I do give all my patients crutches, and you will be non-weight bearing until I'm able to see you.
Okay. See, and this one touches base on what we talked about earlier. You had mentioned not swimming until after 12 weeks. However, if the sutures are removed sooner, would somebody be able to get into a pool?
Yeah, absolutely. I mean, some people's skin heals a lot faster than others. On average, I tell people all the time not to soak their feet because even still, once your incision site is healed, I don't want any breakdown of that skin. When you're in the pool for a long time or in the bath for a long time, your fingers even get wrinkly, so that's kind of treat it like that. Like don't soak your feet for very long after your suture site heals. But yeah, if the integrity of your skin is great, then by all means, yes, you can swim sooner than 12 weeks.
Okay. If I'm on blood thinners, would that put me at risk of not being a candidate for the procedure?
No, you will be a fine candidate for the procedure. Prior to surgery, you will have to stop your blood thinners, though. Depending if you're on Coumadin or warfarin or taking aspirin, I would have you stop a week prior to the surgery at least. And then you can start back up on those blood thinners the day of your surgery after the surgery is completed. You would have to undergo surgical clearance. If it's a heart issue as to why you're having the blood thinners, then your cardiologist would have to clear you for surgery to let us know that it's fine for you to be off your blood thinners prior to the surgery.
Okay. Is it possible to have I may mispronounce this, but is it possible to have Lapiplasty procedure if you have osteopenia?
So the osteopenia, osteoporosis, they're similar in the fact that I'll just have to be really cautious about the post-operative course, which means that your non-weight bearing period might be a lot longer. You might have to get a bone stimulator, and then your risk of a non-union can be go up as opposed to a normal average patient. But you can still have the Lapiplasty. It's just a little bit more risks involved, but it's doable.
Okay, and this one is similar to our MRI questions. Will the metal set off the alarm at the airport?
No, no metal will hope and be set off. PSA would have a lot on their hands if everybody's walking through with bunions and hip replacements and knee replacements. So I think you'll be good.
Okay. This one, how long does the surgery typically take, and is this an outpatient procedure?
Yeah, so it is an outpatient procedure. Usually patients are in and out. They go home that very same day. It's usually taking me anywhere between like 45 minutes to an hour and a half to do the surgery. And it depends on if anything else is being done. But usually surgeries for the foot don't last more than 2 hours.
Okay. And is this something that's done with general anesthesia? What is the process for that?
So yes, I'm requesting that all my patients get general anesthesia. For patients who are afraid to undergo general anesthesia, I have them speak directly with their anesthesiologist, and usually they can do like a popliteal block or like a nerve block of some kind. But I do require you to go to sleep, so this way you don't move around. But yeah, general anesthesia is generally what I'm doing.
Okay. And this is a good one too. If I have a mild bunion or it's really not causing me any pain, should I still get the procedure done?
So I always have a conversation about that. I like to do surgery to fix pain. It's hard to tell people to, hey, let's go undergo this long recovery period for something that never hurt to begin with. So I would wait till it starts to hurt, but at the same
How often should somebody bathe or shower after this procedure with their foot? Do they need to wrap their foot? What is the process for that?
So after the sutures come out, I'm telling my patients to wash their foot separately from the rest of their body, because if you think about it, everything kind of flows towards the feet. I don't want your hair grease or anything getting in a suture site that's fresh and healed. I am directing my patients to get what's called Vosh. It's pretty much a wound cleanser, and you can wash your foot with that. But I'd prefer patients not wash their foot until after the sutures come out. They're seeing me pretty often, like once a week after the surgery until the sutures come out. So I clean the foot and make sure it's sterile and nothing can cause infection.
Okay. Would this fix or get rid of my tailor bunion?
No. So the tailor's bunion is on the outside of the foot near your pinky toe. And that's a different biomechanical structure. Like you can't really rotate that fifth metatarsal base like that. Basically, the two-dimensional bunionectomy is what you do for the tailor's bunion, or if depending on if it's not that big, you can just kind of do a minor shaving of the bump.
Okay. Should the bump be totally gone after the procedure is done? Will it go completely flat?
It should, yes. The bump should be all the way gone, but you have to keep in mind that the head of your metatarsal does have a specific shape. It's not supposed to be like a box. It's not supposed to be square. It is a slight rounded kind of edge, and that's because you want that ball and socket kind of joint for your first metatarsal phalangeal joint. You want that motion there, and if it's too boxy, we're not going to have that motion. So yes, the bump should be gone, but your bone should still maintain its normal shape.
Okay. Really good questions. So here, thank you for answering all of these.
Mm-hmm.
Let's see here. If you could, I know because we kind of mentioned earlier, we had some questions. I know you talked on it during the presentation, but will you be cutting the bone when you do this procedure, similar to a bunionectomy?
So no. So the two-dimensional bunion procedure has you cut straight through the bone near the head. In the Lapiplasty, we don't do that. So we basically go in the midfoot, and the joint that's already unstable, what we're doing is we're moving the cartilage from that unstable joint, and then we're able to rotate the whole bone and fuse that bone into a better position in the midfoot. So it's not like we're creating what looks like a fracture of the bone. We're keeping the same shape of the bone. We're going into a joint where there's already instability and then stabilizing it.
Okay. Here's a very specific one, a good one for you. My second toe is overlapping my big toe to about a 40-degree angle. Will that be addressed with this type of surgery?
Yes, so off of the degree that you're saying it is, you might need a second procedure on the toe itself, like a hammer toe procedure, or even working on the head of that second metatarsal, because that sounds like your second toe is not only overlapping your first toe, but that it's dislocated from its own metatarsal head. So it sounds like you need a second procedure in order to fully correct for your issue.
And this one is, how often will I have to return for a post-op visit?
Well, we get to know each other pretty well. This is the first 2 weeks. You'll come back every week. Once I remove the sutures and we have our first set of post-operative x-rays, we push it out to every 2 weeks, and then every 3 weeks you see me until you're fully healed. I like to not fully discharge my patients until they're about 85–90% better. And so that varies from patient to patient. But the first couple weeks we get to know each other pretty good.
Okay. And I know we've answered some questions regarding arthritis. Have you done this procedure in anybody with rheumatoid arthritis?
So yes, but it depends on the severity of it. Like some people who have like early stages of rheumatoid arthritis and they don't have any destruction of their first metatarsal phalangeal joint or that big toe joint, then I do think the Lapiplasty is a good procedure. If you're a person with rheumatoid arthritis on the more severe spectrum where your joints are already very much so destroyed, I am considering more so a fusion, because rheumatoid arthritis is a autoimmune disease that degenerates the joints. So the most definitive procedure, or the procedure that will help you not come back for more procedures, is a fusion as opposed to a rotation of the bone.
Okay. Is Lapiplasty limited to only small or medium bunions? Could you operate on a large bunion? Or could a bunion be too severe for you to operate on?
I have operated on some of the biggest bunions I've ever seen with Lapiplasty, and the transformation is simply miraculous. I honestly don't believe there's a bunion too small for Lapiplasty. I think that there's one reason why you have a bunion, so you should address that one reason instead of trying to, just make it look nice. So I like doing the Lapiplasty for small and enormous bunions.
Outside of, getting back to, shoe wear, I know we talked about running shoes and shoes earlier. What about something like, how quickly could somebody go back to putting like a ski boot on if they were going to go skiing?
That's a good question. I think probably you want to wait to do any type of skiing, especially if you're like an intermediate to advanced skier. You would want to wait a good 4 or 6 months to get back at it. I would start off like when you first get back into shoes at week 7. I tell people you want to start off small. Like, why don't you ride a bike? You can, walk the treadmill on incline and then see how your body takes it. But if you're trying to do like a ski trip within 4 months after a bunion procedure, I probably would be cautious about that. Do a bunny slope.
Would there ever be a reason you would have to remove the hardware or remove the plating?
If it bothers the patient, yes. Excuse me. Yeah, sometimes patients just have irritation with hardware. It's very rare. I mean, I've been doing the Lapiplasty for a while now, and I think I've maybe removed one plate, and I removed that plate and then did the other foot, so it didn't hurt that bad. It was just kind of like, we're going into surgery anyway. Might as well remove it.
Will I be able to flex my big toe after healing?
Yes, that's the main point with the Lapiplasty. We're supposed to give you more range of motion in your big toe. It can be stiff afterwards. Like a lot of patients do will have scar tissue buildup, so you have to work it out a little bit. But no, you should have range of motion.
Will this procedure affect the width of my foot? Well, will I have, like, as far as the shoes that I'm wearing afterwards, will I be able to wear the same kind of shoes I did before? Will I have to get new shoes?
Your foot might be more narrow. If you're having a bunion, you'll probably have a really wide forefoot. By correcting for it, your foot could be more narrow. So yes, you might have to buy different shoes.
Okay. Let's see. This one, another kind of repeat one, but when can I resume, exercising, activities along those lines after getting the procedure?
You can start with light activity after week 6 once you get back into shoes.
Okay. And could somebody use a knee scooter instead of crutches until they got in a walking boot?
Absolutely, yeah. People rent knee scooters all the time. You can do anything to not bear weight for the first week or 2.
Okay. And you would recommend the 2D procedure over the Lapiplasty bunion procedure based on the severity or non-severity of a case?
The only times that I'm recommending a 2D procedure is if a previous procedure was done before that didn't fully correct for the bunion, and a 2D was less risky or more optimal surgical procedure. But it's really rare that I'm doing 2D bunions really anymore.
Okay. Let's see here. Get some more. Thank you again for taking all the time to answer all of these.
Yeah, no worries.
Let's see. My big toe is bent to the point that the adjacent toe extends out farther than the big toe. This is causing me severe pain in the tip of the adjacent toe. Will Lapiplasty correct this?
So it sounds like the big toe is touching the second toe, and the second toe is what hurts. So yes, the Lapiplasty would help because the big toe would then go straight, and then it won't press on that second toe. So it could really free up the space for the second toe to be free.
Okay. And I know we talked about this one earlier too, but can I get both feet operated on at the same time?
Anything is possible. The willingness to undergo the recovery process is what worries me about doing 2 at a time. I can't speak to this enough. I have done it both before at the same time. Notoriously, everyone who undergoes 2 feet regrets it at some point during recovery. I do think that if you want to hurry up and recover, you should do 1 foot and then 7 weeks later do the other foot. It doesn't extend the recovery time that much, and it's a lot safer. But yeah, it can be done. You would have to get a couple of people who really love you to help you out, and then go from there if you do 2 at a time.
Again, this is a follow-up one to your tailor's bunny question from earlier. If I'm getting a Lapiplasty procedure performed, could I have the bunionette or the tailor bunion corrected at the same time?
Yes, absolutely. I do adjunct procedures all the time. Like, there's no reason to go in for one thing, and if you have another little thing, to not do it at the same time. But like I said, it does increase the length of the time that you won't be bearing weight. So with Lapiplasty, you can bear weight at around 1 or 2 weeks. If you have any other adjunct procedure done, just know that it's probably a minimum of 4 weeks of non-weight bearing.
Okay. And there's a specific one. Have you ever treated somebody with lupus? Are you aware if lupus would preclude somebody from being a candidate for the Lapiplasty procedure?
So I have treated someone with lupus before. It doesn't exclude you from having undergone the Lapiplasty procedure, but again, you would have different types of risks associated with it. So we definitely would have to be having a lot more precaution. So weight bearing early is probably not something that I would do, and we would take it day by or week by week based off of your X-rays.
Okay. Listen, what if you also have neuropathy in the foot?
So it depends on the reason why you have the neuropathy. If you're diabetic, I'm optimally, I'm not doing any elective procedures on diabetic patients unless your A1C level is below 8. Optimally, I'd like it around 6, but yeah, so it depends on the reason for the neuropathy. And then again, the aftermath for you would be very different because you wouldn't feel pain as the normal patient. So you'd have to really use your other senses, like your eyes, my eyes, someone else's eyes, to kind of like figure out if there is signs of infection or if you're not healing appropriately. Like those are the things I would be concerned about, but it doesn't exclude you. It just gives us a little bit more to be worried about after the surgical procedure for healing. I don't think I hear you. If you're speaking, I didn't hear anything. I'm sorry. Nope.
Can you hear me, Dr. Vincent?
Yeah, I can hear you now.
Sorry, my audio cut out there. I'm sorry. If I wear orthotics now, will I need orthotics after surgery?
So if you're custom inserts, then I would think that you wouldn't be able to use those custom inserts after the surgery because we are biomechanically changing what your foot looks like. Depending on the reason why you have those inserts, you could still need them after the Lapiplasty. But ideally, you hopefully wouldn't need them after the Lapiplasty procedure.
Okay, thank you. And this, I'm not familiar with what this is, but you might be able to answer this better. Could I do twilight anesthesia as opposed to general anesthesia?
It's been done before, but I'd prefer you to go under general because a lot of times under twilight, people still move, people still twitch, and it's not optimal for the surgeon if you have a kind of a wiggly patient. If you're gonna undergo twilight, I'd prefer people to have like a nerve block so that way the leg just doesn't move. That's something that we can talk about with anesthesia. But I'm preferring you still consent to have general anesthesia in the event that you're still moving around during twilight, because I definitely don't want you to undergo a procedure and have your foot move with sharp objects around.
Okay, this says, I am having a burning pain in the bunion area and on top of my foot. Would the 3D bunion procedure stop this burning pain?
Ideally, yes. The bunion can compress, like the bump itself is like probably lying on the medial nerve that's there. So the burning pain is a nerve pain. And so if we can release the bone from laying on that nerve, the nerve should hopefully relax and not burn.
Okay, similar to the arthritis questions, if one is prone to attacks of gout, does that disqualify them from having the procedure?
No, it doesn't disqualify you, but with gout, the gout settles in joints. So the most definitive way to not have gout in a big joint is to fuse the joint. I have done bunion procedures in patients with gout, and they're happy. They have range of motion, they get on gout medication, and hopefully never have a gouty attack again. So it depends on the severity of your gout, how well controlled you are, what you're willing to do diet control wise, as to if you want the Lapiplasty. Sometimes I'm doing the Lapiplasty and people still have the episodes of gout, and consider later on undergoing a fusion of the big toe if the gouty tophi gets built up in that joint area. But like I said, gout is, it's very relative based off of the severity.
Okay. Since this is a deformity, and you mentioned it during the presentation about genetics coming into play, if I have a bunion on one foot, does that mean I will develop a bunion on my other foot?
No, not necessarily. People can have bunions on one foot. People can have bunions on both feet. I would say fix the one that hurts and don't worry about the other one until it starts to tell you to worry about it.
Thank you. Let's see. Again, to repeat question, the person apologizes. They joined late, so apologize if you this already. But do you need to cut into the bone like another bunionectomies?
So we're not cutting the bone like a fracture, like across the bone. We're not misshaping the bone. We're rotating the bone. And if you happen to have more of that arthritic buildup on the head of the bone, that's the only portion that I'm cutting off. And that's the portion that was built up that you didn't need in the first place. So I'm not cutting the bone. The bone is not misshapen. I'm rotating it. And then if there's excess bone that's been building up over time, we get rid of that.
Okay, thank you. Let's see. A couple questions too. You'd mentioned earlier when we talked about where you serve your patients. Will you see patients, or do you see patients that come from outside the Orange County area?
Yes, I do. I see a lot of patients that come from out of state. What I normally do for my out of state patients is we do everything mostly on telemedicine. I'm asking for clinical pictures. I'm asking for weight-bearing x-rays to be sent to the office. We speak a few times on telemedicine in order to make sure that this is something that's beneficial for you. But then when you do come out to California to have the procedure, I am requiring at least a 2-week stay here because it's not great to do the surgery and then fly back on a plane. The altitude will increase your chances of developing a blood clot, which is a medical emergency. So I like to see my patients first week post-op, second week post-op, get you out of that realm of having developed a blood clot or infection, and then you can go back home. So it is quite a long stay for 2 weeks, but it is something that makes peace of mind, and we both sleep better at night knowing that we're minimizing the risk in the aftermath.
Okay. Let's see if we have here. So I answered that question, so thank you for that. Going through, we got just a few more questions we want to get through here, and some great questions coming in. So thank you everybody for doing this and for submitting all of your great questions. I have corns on my little toes. Is that something that could also be corrected during the procedure?
Sure, yeah. Depends on what needs to be done, but yeah, little toes can be done as well as the Lapiplasty for sure.
Okay. And will this significantly shorten my toes in any way?
You will have some shortening, but not in any significant kind of way. The only times that I'm worried about that is when patients also have a condition called metatarsalgia, where your second metatarsal is incredibly long. If that's the case, then I would tell you preoperatively or before I do the surgery, like, hey, you might want to consider shortening your second metatarsal. The parabola of your foot can be more sturdy. So I'm not really concerned about shortening of the big toe because it's very minimal bone that we're resecting to rotate this this bone. But if you already have a longer second toe, you could notice this.
Here again, see, just to address it again, if I have arthritis, would that preclude me from being a candidate?
No, I mean, I'm taking weight-bearing x-rays for all of these procedures prior to doing so. Arthritis is a blanket statement for just degeneration of cartilage. So there's varying degrees of that. If you have a small amount of arthritis in the area where we're going to do surgery anyway, then you're perfect candidate for Lapiplasty. If you have more of a rigid toe or something that's more involving the first metatarsal phalangeal joint as opposed to the midfoot, then we'd have to discuss what the best option is for you.
Okay. And then we'll close out with this question. Is there anything I can do to help with the scarring after the Lapiplasty procedure?
Yeah, there's a lot of different scar creams that you can definitely use. I'm recommending more so organic things for my patients. vitamin E, shea butter, cocoa butter, things of that nature can definitely be healing to the scar. But like I said, most scars heal very well. If you do happen to have like a hypertrophic scar or the ability to keloid, I am giving some patients cortisone injections into the incision sites, and that really does flatten them out and deflate them. So there are options for your scars healing after surgery for sure.
Thank you, Dr. Vincent. So as we begin to wrap up now, if your question did not get answered or you think of something later that you wish you'd asked, please feel free to reach out to us. Our email address is patientinfo@treece.net. You could also learn more or find a local doctor by visiting our patient website, alignmytoe.com or lapiplasty.com. Don't forget that as a follow-up, we will email all registrants an archived webinar link for reference early next week. We hope you found the information presented tonight helpful. Dr. Vincent and I appreciate you joining us, and have a wonderful rest of your evening or night. Thank you very much.
Bye.